I am Dr. Karthikeyan, consultant neonatologist based in Dubai. I am going to talk on minimally invasive surfactant therapy. As a introduction to me, why I am involved with Coimbatore enough. I was the founder president of the National Neonatology Forum, Coimbatore, India. I take pride in saying that I was impressed by this minimally invasive surfactant technique ever since I came to know about this procedure and heard from the stalwarts of this procedure from Europe. That was in 2017 Arab Middle East Neonatology Conference held in Dubai. That was a time when I had restarted, I would say jump started my career as a neonatologist in Dubai. But thinking over how can a surfactant be given? The surfactant is a medicine, it's has to be administered to the lungs. Here's action is in the lungs. It's usually given by an endotracheal tube. And how can you conceptually think that it can be given by a feeding tube while continuing the baby on non-invasive respiratory support? Going back to olden days in 1990s, while attending a delivery complicated by mechanism and liquor, we used to press the chest tightly, not allowing the baby to breathe until the baby comes to the resuscitator, suction the mouth and intubate to look and suck out all the meconium that is in the airway. I can say it was a meconium phobia, a foreign body phobia. Real, because pediatricians are always worried about foreign body, and meconium is a foreign body. And we all know there was at that time a daily suction trap that was routinely used to suck out the meconium from the trachea by directly inserting into the trachea and the laryngoscopic guidance. And in fact, it has to be the suction has to be performed by the operator itself. But as the times evolved, guidelines change, recommendations also change, and no such heroic efforts are advised to achieve meconium clearance in the current guidelines for mechanism channel like or deliveries. Hence, we shall not attempt to routinely suction the meconium until and unless we are trying to support the baby's breathing by artificial ventilation. Now, first of all, why I am telling is that SMA, we are not intubating using endotracheal tube. The daily suction catheter we had manipulated or maneuvered to enter the trachea during those days. So that can be easily adopted into clinical practice to do this minimally invasive surfactant therapy. I have a procedure video which comes towards the end of this presentation. Now, I was so much impressed by this non-invasive respiratory support that it became the default way of my neonatal respiratory support curve ever since I started my innings in India and then continuing here. Since 2005, non-invasive respiratory support has become the way of support. I will present a scenario. Assume that you are going to manage a 1 kg baby with non-invasive respiratory support. Conceptually and by the logic of it, non-invasively means that the baby maintains spontaneous breathing and is supported by little extra support without going in for intubation and ventilation, that is hooking on to a routine mechanical ventilator. This gentle, softer way of administration of surfactant, which is a way to give the surfactant while continuing the baby's on non-invasive respiratory support, is conceptually innovative. The learning curve for any innovation depends upon the skill level and the ability to grasp things. When CPAP was introduced in early 2000, the learning curve to use it was variable in different units. And supporting babies on CPAP less than 28 weeks, say 1 kg, was conceptually difficult for many people to grasp it, leave alone understand that. One thing is you have to assess the spontaneous breathing of a baby, able to know how to assess the adequacy of spontaneous breathing, and this is his art which has been matured over years by experience, and with knowledge you mature faster. Non-invasive support has got a distinct advantages that we have chronic lung disease which is less than what you had seen before, fewer airway complications, fewer infections, reduced inflammations, and there is less stress for babies, families and the staff. More importantly, the economics of the care because of the reduced number of oxygen days and the NICU stay. The cost of oxygen people would have known during COVID times. Oxygen is itself is availability is a problem, and cost of oxygen everyone will understand that, and the cost of ICU care inbuilt. So this will save the precious money for the parents and the babies. So this is a major stress which is relieved for the parents, and the staff's work pattern is also less stressful when you have non-invasive respiratory support. And a baby is intubated by per se means you have to be on the wing watching for the tube complications, which is not the case when your unit is tuned to non-invasive respiratory support. So, with their intubation, why intubation should be avoided? So, intubation is an invasive procedure, a laryngoscopy assisted procedure, and using sedation and analgesia, sometimes anesthesia as well is required. Endotracheal tube is a foreign body of the trachea. The time when you are planning to intubate, the baby is not on any support, not even oxygen when you are doing intubation. The procedure needs to be completed 20 seconds to avoid procedure-related side effects like hypoxemia. So, its recommendation is that if you cannot intubate the baby within 20 minutes, reinitiate the baby on support or bag and mask and then attempt it again. Otherwise, baby will go for desaturation. Hypoxia, even brief periods, should be avoided exactly because hypoxia followed by hyperoxemia is more dangerous. Regardless of the severity of the respiratory disease, once intubated, barotrauma, ardelic trauma, biotrauma, and sepsis are unavoidable consequences. The pathogenesis of biofilms, described in relation to neonatal long lines, involves a foreign body conduit that goes coated with a slimy layer amalgamated with pathogens that are released into the circulation, leading to a persistent focus of infection that harms these babies. Recent literature suggests that the biofilms of pathogenic bacteria exist as well with the endotracheal tubes, and there have been trials of silver impregnated endotracheal tubes in reducing incidence of nosocomial pneumonia in ventilated adult patients. Previous anatomical histological studies using infant airway specimens of dying ventilated infants could detect significant bacterial colonization and submucous injury that starts as early as fourth day of commencing ventilation through the endotracheal tubes. These were for more mature babies. So, logically speaking, a premature baby's airways could suffer these same issues even before that. Hence, the impetus is to avoid intubation whenever possible and remove them as early as possible. So, now here is the balance. The equipoise of evidence as it stands now is overwhelmingly in favor of non-invasive ventilation. I would say this includes the minimal invasive surfactant therapy also, as opposed to intubation and invasive ventilation. Right. Previously, what we were doing is the INSURE way of administering surfactant that was conceptualized in the late 1990s or early 2000 in Scandinavian countries to minimize the need and the duration of endotracheal intubation to the extent possible. In this INSURE way of surfactant administration, the babies that are on non-invasive support or administered surfactant are chosen FiO2 cutoffs with as minimal period of invasive ventilation as possible before returning the baby to non-invasive support. Clinical acumen and wisdom should prevail at deciding the appropriate FiO2 cutoffs to consider the escalation of support with surfactant therapy. In the best neonatal units, the chosen FiO2 cutoff is 30% and in any case not exceeding 40%, so that you can get off from the intubation for a prolonged period. Even the briefest period intubation is harmful. I said, no? In mature babies, in experimental studies, real human specimens, you will find mucosal injury, evidence of infections and pathogen colonies starting from fourth day. That is for mature babies more than 2.5 kilos or 2 kilos. When the babies go immature, these injuries and the infection risk will multiply many-fold and might happen earlier as the surfactant thereby has to be given at the early FiO2 cutoffs of 30%, not even 40%. This is why. Because if cost or other consideration delay this and you continue until the baby is on more than 80% oxygen, say, failure of non-invasive ventilation will ensue and baby will end up to be intubated for a prolonged and intensive support with mechanical ventilation, and on many occasions this will lead to escalation to beyond surfactant and conventional ventilation like high frequency oscillation in nitric oxide. This was amply proven in a recent review of all babies who are referred for ECMO, term patients or term babies who are referred for ECMO. They found that the initial first day of respiratory care is very important, and they found that babies are allowed to go on requiring high FiO2 thresholds. Having said that, surfactant is a medicine that has to go to the lungs where it has to be delivered and where it has the action, the airways, the air exchanging epithelium. So here is the catch: how to give surfactant without intubation. Now, enter the mist. Basically, INSURE has drawbacks because 10 to 30% of INSURE babies remain mechanically ventilated post surfactant, and I would say, and I can gather that this percentage is even higher in India. Even in Western countries, 10% of those babies treated with INSURE remain mechanically ventilated for more than 12 hours post INSURE procedure. And then there is a need for ongoing sedation, analgesia for maintaining the baby on ventilation, means intubated ventilation. And once you are on narcotics like morphine, there's not an easy way to reverse it that easily. INSURE way of administering surfactant under controlled ventilation is not equivalent to giving a baby surfactant that is spontaneously breathing. Surfactant administration by mist that conceptually is passing a smaller size conduit across the glottis has advantages twofold. One, glottic movements are not restricted, unlike the case where an endotracheal tube, which prevents the adduction of the vocal cords, and vocal cords are kept in abducted position. And number two, we are maintaining the spontaneous breathing, and recent articles have reported that the dispersion of surfactant across airway epithelium, the air exchange epithelium, it is almost equal to half of the human surface area, more than that also. So you have to diffuse the surfactant across the entire air exchange epithelium. It's better with spontaneous breathing than by mechanical assisted breathing or even bag and mask ventilation, current studies say. Coming to the technical aspect of this minimally invasive surfactant therapy procedure, question is, how will you give the surfactant with conduits that are smaller, tiny, minute? Look at the picture as in the slide. A, B, C, D, E, F. These are all available in the market, but they were not meant for purposes truly for surfactant administration. They were meant for other purposes. A is the infant feeding tube, B is a suction catheter, C is the umbilical catheter, D is an angiocath that is normally used to inject contrast in the cardiac cath lab, which is a 16 gauge long cannula, and E is the current one, is a Lisa catheter, the blue marble, which is specifically made for minimally invasive surfactant technique. The F is the 2-size endotracheal tube. That's the lowest size of endotracheal tube available in the market. Market has not thought of endotracheal tube as a way of administering surfactant. Otherwise, I think a smaller size would have come. But there are drawbacks in using endotracheal tube, however the smaller size can be. I'll come to that later. To say briefly, a 2-size endotracheal tube is equivalent to 8 French infant feeding tube, going by the diameter of it. But unlike the feeding catheters, semi-rigid catheters like the 2-size endotracheal tube and Lisa catheter are technically easier way of administering surfactant and minimize the procedure time. This is very crucial because baby is under support of breathing, and if you have a procedure which takes time, consumes time, baby is going to go for hypoxia, and babies are dependent on respiration. The cardiac arrest algorithm, the resuscitation algorithm is breathing support always before the circulation comes. So if breathing anything happens, then it will go to affect the heart as well. So support of breathing is very important. Basic concept in neonatal resuscitation. Next slide. You see these 4 ways of minimally invasive surfactant therapy that have been conceptualized and are known that can work. Nebulization is conceptually strongest and the most or the minimal non-invasive, most minimally invasive way. But surfactant invasive nebulization is not feasible because multiples or regular doses are required, and surfactant is a costly medicine using 10 times of the dose or say even 3 times of the dose which is recommended in the normal way is limited by cost considerations. The current techniques of nebulization are not enough to aerosolize the concentrated phospholipids into particles that can reach the distal airways. Instillation via laryngeal mask is also not a practicable solution due to the lack of availability of appropriate sized preterm laryngeal mask as the things stand now. Threading a thin infant feeding tube aided by Magills or unaided by it, and semi-rigid vascular angiocaths like the Lisa catheter and the smallest sized endotracheal tube or the conduits or the catheters that have been reported in literature is performing the minimally invasive surfactant technique. I have performed MIST using all these techniques in Dubai successfully. Magills, as you know, was a German invention. A Magills forceps is designed and facilitates nasotracheal intubation, which is the default intubation technique in some leading NICUs like the Addenbrooke's in UK. And threading a thin flexible infant feeding tube unaided by the Magills, it needs a lot of experience and technical expertise. In Dubai, after publishing initial success with the missed way of administering surfactant in consecutive 3 preterm units in October 2018, mist became the default way of administering surfactant in the units of Dubai, where I was the clinical lead. The US, the Canada, and the UK neonatal units are not even doing mist as a routine at this point of time. Europe was the leaders in doing minimally surfactant therapy since 2009. And this was because the more you perform the procedure, the more you become skilled in it, and you have a large population to study the outcomes comparison with what was done previously. This is the way medicine evolves, slow but steady way. Equipoise of INSURE later tilted in favor of mist, recently as the last year I would say. Projected in here is my published pilot report of 2018. The 3 premature babies that are of gestational age 30, 35 and 28 weeks with corresponding birth weights of 1.03, 2.3 kilos and 1.18 kilos. All of them were successfully treated with surfactant, never needed intubation and ventilation, and they changed the mechanical ventilation and went home and are doing fine with a good long-term outcome as far as follow-up time is allowed. Having this is success with this mist performed using thin feeding tube technique. I would say that I used Magil only for the first instance in a first baby, the 35 weeker, 2.3 kilos. After that, I have understood the procedure and have developed this expertise that I can easily perform this procedure with the infant feeding catheter unaided by the Magils. I would say this avoids the pain and the need for sedation and analgesia, which I had used in that big baby, 35 week 2.3 kilos. Then I was thinking that why not use for a bigger baby, say 36 weeks, why not just use a smaller size endotracheal tube? The problem is that in the usual way it is done, the INSURE technique I mean, once the endotracheal tube is guided in the trachea, you again thread a feeding tube through the endotracheal tube. This I wanted to avoid. So the difference is how do you insert, rather put an endotracheal tube, and through that, eh, without the infant feeding tube, can we be able to give the surfactant? And in fact, conceptually speaking, mist is just threading the feeding tube without placing an endotracheal tube in the first place. Correct? Do you understand the difference between INSURE and this? Rather than putting an endotracheal tube and into using that as a groove into which you guide a feeding tube, it's just that you should be able to thread the feeding tube without the endotracheal tube. Understand this logic. Threading another catheter down the endotracheal tube means almost no lumen is left, and hence the resistance is very high. So I tried my own benchmark studies and found that this 2-size endotracheal tube, the nozzle of it fits the nozzles of the syringes. Once you remove that adapter, it does fit the syringes, nozzle of the syringes. So it's easy, but you have to be very quick in doing that. In fact, load the surfactant, attach it, keep, and by this way you'll be able to quickly do it. Otherwise, time will be wasted in attaching the syringes. The attachment of syringe is the important thing. And I had experimented with this for 2 days before the next preterm surfactant treatment came, which I performed comfortably with the 2-size endotracheal feeding tube. And after that, I have done at least 3 or 4 times. And I have shared this experience in US Permanent Indexed Journal. And this was, trying to say, my study has been quoted by recent review by reputed German researchers in 2020. Coming to my maiden miss procedure, the thin infant feeding tube with the narcotic loading dose, I gave morphine and also a midazolam dose also. So soon after the surfactant had been instilled via the feeding tube, saturations will drop. At this time, your heartbeat also will hold on for some time. Mine will say intubate, but I continued on nasal CPAP, increase FiO2 by 10%, and the lowest SpO2 that dropped was up to 66, and then the baby started to come up in saturation and came to 85 plus within 2 minutes. And that was a big baby, 2.4 kilos, that I needed Magils to introduce the feeding tube at that time. I had gone through the video of the procedure many times and conceptualized that it is the narcotics that I gave before the procedure, and the 5 to 8 minutes time that it took for me to pass on the feeding tube on the trachea and the Magils forceps were the reasons that this desaturation happened. Hence after, I have improvised the technique so much that it's now easy meat for me. Now on minimally invasive surfactant therapy, I have 15 babies who received surfactant on 17 occasions, and on 10 occasions I used infant feeding tube. That's the way Germans do it. Okay. It's called the Hubbard technique. Next, there was this baby in whom I performed mist using the Lisa catheter presented to me by Professor Kaj. Kasia Bolin of Karolinska Institute, Stockholm, upon whose invitation I had gone there for a clinical attachment in January 2019 for 10 days. Then I had published this two-size endotracheal tube way of mist, my own invention or improvisation, you can say. I done many times after that also. It's easy. It can be done anywhere for the bigger baby, not for smaller babies. Curious of, I use the correct dose, 200 milligram per kilo. I usually err on the higher side of the dose because don't waste Curacao. Don't err on the lowest side as the medicine is costly and no side effects will ensue by going this dose slightly higher. In my whole cohort of babies, I didn't publish. You can see the published article. That's a compilation of 15 times procedure in 13 babies. After that, I have 2 more babies. There was misfailure in only 1 baby. By definition, failure is defined as a need for intubation or mechanical ventilation within 72 hours post the procedure. Only one of my babies needed ventilation, and including this baby, all my babies have had intact survival. I have this follow-up data also reported post evaluation at the age of 3 months to 2 years of follow-up age. The video that will be shared here at the end is an 8 minutes video. It's the latest I have done in April during COVID times. This is performed as a thin infant feeding tube. I have endotracheal tube video also, missed also. It's available already loaded on the YouTube. I will give the link. People can view that also in my channel, NeoG. So from an analysis of missed babies, I have these take-home messages for the audience. 1. Missed is a procedure that is technically easier to master by skilled neonatologists. The clinical outcome post-missed is not influenced by the type of surfactant. See, good thing, like you think that surfactant administration through INSURE or even through the smaller catheter might be difficult because of the volume which is higher when you use Surfactant. Surfactant dose is 4 ml per kilo, which is supposed to be equivalent to 100 milligram per kilo of Curacao. The volume for which will be 1.25 ml per kilo. So 1.25 ml per kilo of Curacao is supposed to be equivalent to 4 ml per kilo of Surfactant. In my experience, that I had used Surfactant even for smaller babies, 28 and immature babies also, and the clinical efficacy is not inferior to the Post INSURE surfactant Curacao in this small Dubai cohort. To enable the surfactant reach the air exchanging alveolar sacs and spread it across or the gas exchanging alveolar surface, the reflex of surfactant has to be minimal. Reflex was a common problem in many studies. This avoiding the reflex, I achieved by dividing the dose into. I didn't have. People attempted to divide the dose into multiple small liquids, but when you divide into multiple small liquids, you give enough time for it to return back by peritubal leak. I mean the peri-infant feeding tube loop in the instant case of minimal surfactant technique. I repeat, you may think that dividing the dose into multiple small liquids. 2 issues. One is that you give enough time for the surfactant to return back by peritubal leak. Without, if you don't ventilate in between, the surfactant is not diffuse and it will reflex time is more, and by prolonging the procedure time, your chances of failure at missed are higher. So whereas for INSURE, if you use Surfactant, you might achieve it by dividing into multiple smaller liquids, multiple positions, because anyway baby is going to be continuing on ventilation for at least some more period after you give surfactant by intubating the INSURE way. But here we don't have the leeway, the time leeway is not there when you use a small feeding tube technique or even Lisa catheter. Lisa catheter you cannot ventilate. This year you cannot ventilate in normal way using the conduits used for minimal surfactant technique. So it will be quite fast and it is reasonably sure that baby is able to withstand the procedure and quickly come out the procedure and be stabilized on non-invasive respiratory support. So it will be very pretty quick and you have to judge your cases and assess clinically also so that failure risk is not there. How I minimize surfactant loss is that if you are not fast enough, leak and surfactant loss will be more. So I flush the feeding tube with air gently at a constant pressure using a syringe. I normally have syringes filled with air that I used to gently flush and diffuse the surfactant through these small catheters, whatever catheter I use, and be fast is what my advice. I infer from literature that colleagues elsewhere in Europe as well administer Curacao faster in less than 60 seconds. I timed myself. I finished giving surfactant in 10 seconds. Once threading the catheter and correct position is confirmed. Misusing the semi-rigid catheters like the Lisa catheter, the smallest endotracheal tube, was also easier to use, and studies have found that the technical skills of performing mist is easier to master than the way of threading a thin catheter, especially when you have to use a Megill forceps as well. More importantly, I found that there was no interventional hemorrhage of grade 2 or above, no chronic lung disease, no retinopathy of premature sequel, no sepsis, but importantly, reduced oxygen days, reduced NICU stays for all these babies in the Dubai cohort, and stress relief for nursing staff and the parents. At the end of the work in the hospital, I was doing the procedures. I put the data of the 28 weeks, 27 weeks. People are not even knowing that such things were being done in the NICU of the unit. So that was a silent but strong way of doing things. So these findings are in conformity with the German neonatal network data published recently. So I conclude minimally surfactant therapy is a gentler, calmer way of supporting the babies with respiratory distress non-invasively without losing the control and going for invasion. Next slide. This is your question. Can you answer this? What is EIT in the chat box? To give a clue, this I saw in Barcelona, and lungs are visualized here, and what is displayed in here is the lungs. This is electrical impedance tomography, just like computerized tomography that gives anatomical pictures of the lungs. In this electrical impedance tomography, you have electrodes, like just like ECG electrodes, capturing the breathing movements, and they generate this image as a real-time display of the bellowing function of the lungs. This technology is now used to answer the key question: which way the dispersion of surfactant is better, Post INSURE or the mist? It is used in animal studies. It was found that surfactant administration in a spontaneously breathing lung achieves better dispersion than with mechanical breathing, means the INSURE. So the equipoise is in favor of mist on a strong pathobiological basis. Next, coming to the latest practice in Europe, Lisa catheter was the preferred way of performing mist, with 86% of all the babies receiving surfactant this way in a study from Poland. See, I already displayed the picture. The picture label E, the blue is a Lisa catheter. It's a 13 centimeter long blue marble with markings up to 9 centimeter from the tip, and that has a hub that fits with the syringe nozzle snugly. This is the semi-rigid angiocath prototype. The other things we already explained before, A, B and C. Right, now you see in Europe, Spain data are displayed. All the procedures of surfactant administration 28 weeks and 30 weeks are done by mist way. There is no intubation involved. In coming down on the gestation age, 26 and 27 week gestation as well, 76% receive surfactant by mist. In those babies of lesser gestation, means those 23, 24 and 25 weeks, still they need to be intubated for surfactant. A few factors which are predisposed to mist failure. Number one is the gestation age less than 28 weeks. That's obvious because immature babies need to be intubated for reasons other than for giving surfactant as well. A CRP more than 10, this is infected babies. Infection is common in less than 28 weeks, and so in those babies there's additional damage. Surfactant gets inactivated in infected lungs. So the dosage for surfactant in non-highly membrane disease indications is actually more than that is required for the highly membrane disease. In infection settings, surfactant inactivation happens so fast that its efficacy is negated. And surfactant dose, if it's less than 200 milligram per kilo, cost cutting is definitely not going to help you, even cost wise, because the number of days on oxygen is going to improve and the number of NICU stays as well. And lack of anti-intersteroid course for RDS, they are the determinants of misfailure. So 1, 2, 3, 4, gestation less than 28 weeks, CRP more than 10, surfactant dose that's less than 200 milligram per kilo, they mean only the Curacao. There is no Servanta in Europe for you to be certain. And lack of anti-intersteroid course for RDS. Now I come to some interesting brain teasers for those with the high level thinking in the audience. Please hear me very carefully. Displayed in this graph is the published data from a Denmark NICU, National Network Live. They wanted to assess the missed failure, the incidence and the causations. Now, see the graph. I have modified the graph which is available with the permission from the authors. There are 5 color codes which are displayed in the bar diagrams. And you see gestation 24 to 31 weeks which are displayed on the x-axis. In the y-axis, each bar that corresponds to each week has got color codes. I'll say 5 color codes are there. As you can make out, babies survive only with CPAP, means CPAP alone as the gestation advances, and the percentage of surfactant use diminishes as the gestation advances. This is understandable. Surfactant use, miss success, and surfactant by mist is a bright green band. Miss failure and intubation for surfactant is marked by color code pale green. This is your attempt missed, but then you fail, and then intubation and surfactant is pale green. Primary intubation means the distress is so severe that you intubate. At that time, you give surfactant. It is marked by a pale gray. The minute tail band below that appears from 28 week onwards is intubation for other reasons and non surfactant. It's because after 28 weeks you intubate for some other reason and there is no need to give surfactant after that. Recommendations say that immature baby needs intubation for respiratory distress needs to be given surfactant at the time of intubation. Now study the graph. This graph will be paused for some minutes, I would say. Let me pose the two questions for the audience. I have invented, I would say, I'll take credit for that. I have invented a new NIV 50 concept, non-invasive ventilation 50 concept, which I define is that at each gestation, at 50%, at each gestation, 50% of the babies that can be managed or successfully managed with non-invasive support alone. The question is, NIV 50 cutoff is achieved at what gestation? Means the equipoise is tilted in favor of NIV, the use of NIV I would say, at what gestation? At this gestation and above, non-invasive ventilation, including the way of administration, also non-invasive. Both ways is non-invasive. Ventilation, support, respiratory support plus the surfactant, both should be non-invasively way from which gestation onwards. Number two question is which color code represent surfactant use and which color bands represent no surfactant? This is color bands question. Take your minutes. Coming to the answer, let us explore the first question more thoroughly. That non-invasive ventilation from which gestation onwards has got 50% efficacy. Means if non-invasive ventilation is CPAP and CPAP plus miss success, 50% of babies of which gestation can be managed this way. Means in advanced neonatal units, the skill levels are important in this here. So in top and current updated management of babies, this answer is a graph reflects experience from a leading NAV center. Answer is 25 weeks. You see I have drawn a horizontal bar across mentioning the 50% cross line and there is another so this upper grid and this dog grid, so these two grids, there is another one which is at 70% and 20% as well. So 50% is at 25 weeks. So NIV 50 is achieved at gestation age of 25 weeks. In other words, to translate, babies, preterm babies 25 weeks and above, non-invasive support is the predominant way of managing these babies. That includes the non-invasive way of administering surfactant as well. So that is the current standards in the world. You should be able to achieve that. Now, coming to the next question, which color bands represent the surfactant received babies and babies receiving or successfully managing the respiratory status without the need for surfactant? Answer is the no surfactant is color band 1 and 5 in order from the top or 5 to 1, 5 and 1 from below upwards. So bearing these color codes 1 and 5, that is the topmost and the bottommost bands. You see some gestation there is no the fifth band, the bottommost band. So if you remove these two, the rest all subgroups 2, 3, 4 represent babies that receive surfactant either by mist or by intubation. So answer is no surfactant, color code 1 and 5. Surfactant given color codes 2, 3 and 4. As I already told, if you look carefully, there is no band 5 in less than 28 weeks. That means that all babies have required surfactant therapy in those babies in less than 28 weeks in most of the instances. There is no primary intubation and surfactant use in these gestational age babies. Right, you can study the graph again. I will post this question, this graph again. This graph is very important, like IELTS academic grading question. This graph summarizes all the future trends, how it's going to be the missed way and how we are, and there is scope for improvement is also visible in that graph. Now, I will pose myself one question which I'll answer myself also. From which gestation more than 50% of babies can be managed successfully with CPAP alone, that is NIV, without the need for surfactant? Can anyone answer this? 1, 2, 3, 4, 5. The seconds I'm saying. countdown over. Answer is 29 weeks. How many more immature weeks are saved by intubation trauma is an important question. To make understand the question itself, I have to repeat the question and give the logic of it. Question is, how many more immature weeks are saved by intubation trauma? In other words, by giving surfactant, how many weeks we successfully extend down the success of non-invasive ventilation. So you see, from 28 weeks, babies can be managed comfortably with CPAP alone. And so you have to find the gestation age where babies can be managed with CPAP with the surfactant by mist, not by intubation. That is purely by NIV. So 25, 26, 27 and 28 weeks can be managed by mist in addition to nasal CPAP. So NIV 50 achievement by nasal CPAP alone is 29 weeks. And from 25 weeks, that was a question I posed, question number 1. From 25 weeks onwards, NIV with or without surfactant achieves 50% success rate at 25 weeks. So, answer conceptually, if you'll understand well, we can manage 25, 26, 27 and 28 weeks as well, more than half of them non-invasively by giving surfactant the mist way. Before all these babies, if you practice INSURE, these 4 crucial weeks would have ended up on INSURE and ventilated, and theoretically by mist 4 weeks gestation immaturity we have helped to minimize the barotrauma and the sequel of it, chronic lung disease, intestinal hemorrhage, sepsis caused and the stress. So understand and practice surfactant giving by minimally invasive surfactant therapy. So I have a success story said here. This is a happy mother. Their baby, who is 7 months old, who was only 1.08 kilos at birth and managed with mist. All bright, look great, have a good day. This is Dr. Karthikeyan, neonatologist based in Dubai. Thank you very much for giving this opportunity. Bye for now.